The thyroid is an important metabolic gland located in your neck. In pregnancy, the thyroid gland doubles in size, and the output of thyroid hormone increases by 50%. Women with low thyroid function or hypothyroidism in pregnancy often develop complications, and in fact, these women are twice as likely to develop gestational diabetes mellitus or GDM. In pregnancy, the mother favors the delivery of nutrients to the baby. So, to keep her blood glucose levels above the levels within the fetal circulation to facilitate this delivery of nutrients, she develops a physiological insulin resistance. Insulin kind of acts like a key, and some cells in the body have a door that this key can unlock. In pregnancy, the mum basically changes the locks to some of the doors so that insulin can still unlock and open some, but not all of them. Therefore, enough glucose remains within her bloodstream for delivery to the baby. But she also needs enough glucose to remain healthy as well. So a placental hormone, known as placental lactogen, acts within the maternal pancreas to increase the number and size of the cells that produce the insulin key. These cells are known as beta cells. It is kind of like if you have more insulin keys wandering around the neighborhood, you're more likely to find a door that the key can unlock. GDM can occur when the mother is unable to adapt to the changing of the locks, and the glucose remains within her bloodstream. She then becomes hyperglycemic, which is associated with a range of maternal and fetal complications. So far, the association between hypothyroidism and GDM is mostly clinical, and there is limited preclinical research that is focused on identifying why this link exists. The purpose of my PhD is to develop an animal model of hypothyroidism that focuses on determining what is driving this association between the diseases clinically. In our model, we administer an antithyroid drug from a week prior to pregnancy and throughout gestation. This drug, known as methimazole, acts within the thyroid gland to interfere with the synthesis of thyroid hormone, and our animals quite quickly develop hypothyroidism. So far, what we've found is that maternal hypothyroidism significantly reduces the levels of that placental lactogen hormone within the maternal circulation. As a result of this, our animals do not undergo appropriate beta cell expansion in pregnancy and have low insulin levels. Then when we give them a dose of glucose, they're not able to regulate their blood glucose levels appropriately. What is driving the reduced placental lactogen concentrations is yet to be determined, but the functional compartments of the placenta have changed, such as the endocrine zone, known as the junctional zone, that produces that placental lactogen hormone is slightly smaller. While we've also explored pathways that facilitate insulin resistance within peripheral tissue, so far we've only found evidence of reduced insulin signaling, and still need to determine whether there is evidence of hypothyroidism driving this peripheral insulin resistance. Importantly, if we can understand what is driving the link between these two diseases within a preclinical model, we can ensure that mothers are appropriately monitored for thyroid health in the early stages of pregnancy, stopping them from developing GDM and the devastating outcomes that are associated with this disease.